Okay. Hi, I'm Kristina Murata, and I'm a nurse practitioner at UCLA Medical Center. I've been there for about 15 years and have been in the Division of Pediatric Neurology for about 10 years. I'm also going to introduce you my co-speaker, Jessica Brown from Children's of Orange County.
Hi, my name is Jessica. I'm at CHOC Children's Hospital. I've been there for about 11 years, and I'm the dietitian for the ketogenic program there.
Okay, so just to see what my audience is like, how many of you are here because you have children who have epilepsy and you want to learn more about the diet? Okay, and how many of you here are just interested in the diet and don't have epilepsy but just want to know what is this about? Okay, and how many of you are providers for any institution or any medical field and just want to know what this is about? Okay, and how many of you are adult patients who are inquiring and want to know how this works? Okay, thank you. Okay, great. So disclosures, we don't have any disclosures. There's no conflicts of interest to any of the things in our talk. So let's start with the epidemiology of epilepsy. As you know, the prevalence of epilepsy is large, and there's 1 in 26 people who will develop seizures in their lifetime, higher in younger children and older adults. Oops. And the prevalence in the United States in 2015 shows that about 1% of the population have epilepsy. Of that, 3 million of them are adults, and about 500,000 of them are children. The morbidity. People who have epilepsy have increased morbidity. Over 40% of children have at least one neurological disorder. Developmental delays are the most common neurological disorder. Other neurological disorders are like poor memory and concentration. And other people have other comorbid disabilities such as physical disability, physical injuries, and a lot of psychiatric and behavioral problems that may also occur with epilepsy. Epilepsy also carries an increased risk for premature death, particularly in patients with chronic epilepsy. Sudden unexpected death in epilepsy is a major culprit to increase mortality. We also know that patients who have status epilepticus, accidents, drownings, and suicide can cause mortality. Although most of those affected by epilepsy will be treated and in remission within the first 5 years of diagnosis, there's still about a third of patients who have chronic epilepsy and they become medication resistant. So what is drug-resistant epilepsy? So the ILAE, who is the International League Against Epilepsy, they have defined drug-resistant epilepsy as a patient who fails two appropriately chosen and tolerated anti-epileptic drugs. So it doesn't mean that you've tried it and you didn't tolerate it, but you actually failed it and was able to tolerate it. So most patients who have a diagnosis of epilepsy will try their first appropriately chosen drug, and 50% of these patients will have control in epilepsy. The second drug that they try, if they're not part of the 50% that has controlled epilepsy, then 11% of that next 50% will then have control of their epilepsy on their second drug. By the third drug, if they've failed already 2 drugs, then that leaves them less than 5% chance of controlling in seizures. So therefore, there's at least a third of the population of patients who are diagnosed with epilepsy who still remain medication refractory. And these are when patients should then ask their provider, their neurologist, whether or not a treatment option such as a diet therapy is something that they could start on. So diet therapies are high fat diets or very low carb diets. And these diets are including ketogenic diet, modified ketogenic diet, modified Atkins diet. Those are the very high fat diets, and the lower carb diets are the low glycemic index treatment diet. So for the purposes of our talk, we'll be mainly discussing just the ketogenic diet and the modified Atkins diet. These are the diets that are mainly the ones that we typically offer to our patients and that are used in our at CHOC and at UCLA. But we do also have patients who are on a modified ketogenic diet and a low glycemic index treatment. So let's talk about the history of the ketogenic diet or a ketogenic-like diet. So fasting and other dietary regimens have actually been used to treat epilepsy since at least 500 BC. This mimics metabolism of fasting. And then in modern day history in about the 1920s, there were a few modern physicians who actually used ketogenic diet as a way of treating epilepsy. However, soon after the 1920s started emerging drugs and anti-epileptic drugs, and that became more popular. So a lot of the diet therapies had actually faded until about the 1980s when a movie came out about ketogenic diet. And in the 2000s, we started doing much more research, and now with all the research that's been done, we have actually a lot of centers around the United States and around the world that do actually do ketogenic diet and other diet therapies. So now let's talk about metabolism of carbohydrates just at a glance. So normally, this is our patients, everyone who is on a regular diet, we intake glucose and it goes through glycolysis and then we get pyruvate. When we get pyruvate, then it becomes acetate. It goes through the Krebs cycle and the electron transport chain, and then we get energy. However, with patients who have limited carbohydrates, we switch metabolism and we don't use the carbohydrates any longer, and we use fat. So instead of using carbohydrates as a fuel and a fuel's energy source for our brain, we now switch to fat metabolism. So patients who are on any ketone-producing diet, such as the ketogenic diet, have limited carbohydrates. And they take high volumes of fat. Fat is then broken down to free fatty acids. Going through mitochondrial beta oxidation, we get acetate, and acetate then converts into ketones. And that's how we provide energy for our brain, because ketones then can cross through the blood-brain barrier and provide energy that way. But what other mechanisms of action, and is that the only mechanism of action, is this ketone production that we think is helpful with controlling our seizures? Yes. There are other hypotheses out there. And although I've just talked about a little bit about the metabolism of how the diet works and what we think, there's actually thoughts and hypotheses about whether or not this diet works on GABA receptors, whether the ketone bodies are a neuroprotective anticonvulsant, whether it works on adenosine receptor agonist and other things. So there's actually a lot that's unknown about the ketogenic diet and any ketone producing diet.
So now for a little less science-y part of our presentation, we're going to talk about the food and what this diet looks like. So for a little perspective, we have two pie charts here. The one on the left represents the traditional American diet, where you have about 50% of your calories coming from carbohydrate, about 20% from protein sources, and only 30% from fat. Now compare that one to the pie chart on the right, and you can see how drastically different the calorie distribution is, where you're having, on the strictest form of the diet, you're having 90% of your calories coming from fat sources. Very restricted in carbohydrate, and as you can see, even the protein is quite restricted compared to the traditional American diet. So as Kristina was saying, this diet is a high-fat diet. All forms of the ketogenic diet, whether it be modified ketogenic diet, modified Atkins, is still a high-fat diet. That's where the majority of your calories are going to come from. And so you're going to be including things like mayonnaise and oil and butter, salad dressings, heavy whipping cream. These are things that are going to be the majority of your calories. So for instance, if you want to have tuna with mayonnaise or egg salad with mayonnaise, maybe you'd use heavy cream to make a shake. And so that's going to be where you're getting your fat calories. We do provide adequate protein, although it's lower than the traditional American diet. We provide enough protein for adequate growth and development. So your protein sources are going to be cheese, fish, poultry, beef, and some of your processed meats like bacon and pepperoni as well. And then restricted in carbohydrates. So to maximize the carbohydrate on the diet, we really want to only use mainly fruits and vegetables. So we're removing those high dense carbohydrate foods such as pasta, grains, bagels, beans, potatoes. And so we're really trying to maximize the volume of the food, utilizing fruits, vegetables. We'll do some nuts and then olives as well. So you'll hear the diet is prescribed in ratios. And so what that means is that we're comparing the grams of fat to the grams of carbohydrate plus protein. So you have your fat grams compared to your non-fat calories. And so traditionally we go up to a 4-to-1 ratio. So it's 4 grams of fat to 1 gram of carb plus protein. Although we can modify the diet, and we've had success in treating seizures on lower ratios. So it's very patient specific. For instance, this is an example of a 1,000-calorie diet. And you can see at a 1-to-1 ratio, this patient received 60 grams of carbohydrate per day. And as you increase the ratio up to a 4-to-1, you can see how much restricted the carbohydrate is, 8 grams of carbohydrate per day. To put it in perspective, one medium-sized apple is about 20 grams of carbohydrate. So you can see how restrictive this diet can be. And traditionally, most often speaking, the higher the ratio, the higher the ketone production that one will produce. So this is just a picture showing the difference in terms of the food volume that you would get at the different ratios. And so starting with the green circle, that's your 1-to-1 ratio. So you have some chicken, some mayonnaise for your fat, and broccoli as your carbohydrate. And as you advance the ratio, you can see how the portion of the food gets smaller and smaller because fat is very calorically dense. And you can see even not that we would necessarily syringe oil for our patients, I think just for the picture purposes, they put the oil in a syringe so that you can see that. This might be an example of a ketogenic meal, a typical breakfast, where you have scrambled eggs as your protein source, your strawberries are your carbohydrate source, and then up on top we have our different fats. So avocado is a great ketogenic food. It's naturally a 4-to-1 ratio. And then we have butter and heavy cream. So if I were to prepare this for one of my patients, we would actually mix in the heavy cream and the butter into the liquid egg so that when you cook the egg, it's absorbed. So this looks like a pretty standard regular breakfast, right? This next meal, it might be a typical dinner where it's a stir fry or a play on a stir fry where the white substance is actually cauliflower rice. So it's taking cauliflower, a low carb vegetable, and using a food processor to make it like a rice consistency. And we have some chicken and then some stir fried vegetables and oil. So this is what you would see as a parent or an individual making the diet, is everything is weighed on a gram scale. So your dietitian would provide you specific recipes where each food ingredient is weighed on a gram scale. So this would be the eggs and fruit that I showed you 2 slides ago of that picture, where you would have your heavy cream, 35 grams of heavy cream, you would weigh that on the scale. Strawberries, 52 grams, etc. So every food item is weighed out individually on the classic ketogenic diet. Now, if your child or yourself are tube fed, there's multiple different options where they actually make specific ketogenic formulas for this purpose. There's many different companies that make a variety of flavors. It comes in unflavored, and we even, if you're on a blenderized tube feeding, your dietitian can help prepare that formula for you as well using whole foods through the tube. So multiple different options. Ketogenic kids can still celebrate holidays on this diet. It does take some preparation and forethought, but there's many recipes out there for birthday cakes, for gingerbread cookies, you name it, a recipe is out there for them. Some of our families, we just had Halloween, they get pretty creative to where the kids still get to go trick-or-treating, but then the Wicked Witch comes at night and steals all the candy. There's wrappers littered around the house, and then they get a toy, or they get to go to a store and get a toy of their choice. So there's creative things that you can do using this diet. Kids can still eat pizza with their family. So there's recipes out there to still include the child or the individual on the diet with the family and match the food. The family can eat this ketogenic pizza as well, or you can pair it with a pizza, and so the whole family's having pizza. This is a delicious ketogenic pizza. I made it for a potluck and everyone loved it. The texture was great. You don't necessarily have to have just oil or butter on your plate. There's creative ways to get your fat in. These are some, you might hear the word fat bombs. So these are mainly coconut oil. And when you refrigerate coconut oil or put it in the freezer, it turns solid. And you can make different flavors, like the pink one is strawberry and cream with coconut oil. And then you have a chocolate one. And this mom actually went out and got candy molds and even a chocolate tray to present these to her child. So fun, creative ways that taste delicious. Kids can still go to McDonald's. So as much time as you want to put into this diet, you can make it work. And so this child, his sister got to go get a Happy Meal, and he really wanted his Happy Meal. So we came up with a chicken nugget recipe where we used shredded chicken and mayonnaise and almond flour and an egg wash, and she fried them. We reserved the most, whatever carbohydrate we could do, we gave for the French fries. He still got his toy, and he still got to go to McDonald's with his sister. Kids can still eat carbs. So there's multiple recipes out there. This is a waffle made with almond flour. There's pancakes, there's low carb tortillas and muffins. So you can still eat your carbohydrate foods without the carbs. This diet can be difficult and time consuming, and so our families have thought up ways to help reduce the time in preparation. And so batch recipes are very important, where they're measuring each ingredient and doing maybe 3 preparations of that meal. Everything's labeled in the fridge, ready to go. Really saves time. Making it fun, using different plates and utensils that are fun for kids. And providing these all-in-one meals. So this would be a 3-to-1 ratio, a 4-to-1 ratio, or whatever the child was on. Grab and go, you're going to the doctor's office, you need something easy where you can't have all the food components. Or if your child's a picky eater and they might not finish everything, at least you know they're getting their prescribed ratio with these all-in-one meals. Now, the modified Atkins diet was actually created at Johns Hopkins Hospital. They had a long waiting list to get into their inpatient ketogenic program. A family came with the Atkins book and said, hey, can we try this while we wait? And so the physician said, sure, do the first chapter where they reduce the carbohydrate. And lo and behold, the patient became seizure-free within a few days. And so they thought, there's something to this modified therapy. So this diet therapy is more liberal. It allows families to go out to eat at restaurants. It allows kids to go to birthday parties and making small modifications, but it's more sustainable for older children especially and adults. It started an outpatient, so traditionally the classic ketogenic diet is initiated in the hospital setting, so this is done outpatient. And you're not weighing things on a gram scale. You're carb counting much like you would for a diabetic patient. And you're only counting carbs. So you do have more allowance for protein on this diet, but it's still high fat. So these are some examples where you might have avocado deviled eggs. This is a keto yogurt or a modified Atkins yogurt using heavy whipping cream, where you whip it with a whisk or a hand mixer and you fold it into like a plain Greek yogurt, add some carb-free sweetener to get a nice high-fat yogurt. There's chia seed pudding there. There's a macadamia nut butter sandwich with a low-carb bread. There's muffin in a mug, so multiple recipes where this is almond flour and egg, and you use different spices, and you just microwave it for 30 seconds, and it gets nice and puffy, just like a muffin. And then crispy cheese is everywhere now. I don't know if you guys have seen it in the grocery store. Delicious. You get that nice cracker crunch with just baked cheese. So eating out on this diet, on the modified Atkins diet, this is what it's all about. It's meant to be something that the family, that's sustainable. The kids can go out with their friends, and you can make small adjustments to the diet. And so many restaurants these days have their calorie, carb information online. So just with a little preparation before you go. These are two examples of In-N-Out and then Chipotle, where you can make small adjustments and make it a modified Atkins meal. There's many low-carb products out there and high-fat products. There's, I don't know if you've seen in the frozen aisle, the spiralized vegetables now. So it's kind of like a play on pasta. You have different carbohydrate-free sweeteners. We have some low-carb bagels that you can get, low-carb tortillas, and a lot of these products are actually in just the regular supermarket, Albertsons, Ralph's, so you don't always have to go to these specialty stores. There's a lot of companies too that are making low-carb, high-fat products that you can order online. So there's donut holes and pizza and muffins and sugar cookies. So there's a lot of options out there. Some tools and resources to use with the modified Atkins diet now with apps has made it really user-friendly. So on modified Atkins, we actually subtract fiber to get what we call net carbohydrates. You might have seen that on a label. And so these apps take away the math for us and make it really user-friendly to where you can search your foods and add them into the app, and it does the carb counting for you, so you can keep track of your whole day. And then the Charlie Foundation is a nice resource that we direct our families to. Recipes, information about the diet, definitely the number one website probably to go to for your initial information. Some other tools and resources, I don't know if anyone's on Pinterest, but it's definitely a very good tool to use on this diet. At CHOC, we actually have a modified Atkins CHOC Pinterest page where we post different recipes, different specialty products. And then the keto diet calculator is another resource. On the classic ketogenic diet, your dietitian, this is the tool they most often use, and they can teach families and give them access to use this calculator as well. So you can be at home modifying the recipes depending on what ingredients you have at home. It's important to note that any form of the ketogenic diet, whether it be modified Atkins or classic ketogenic diet, really does require a multivitamin and mineral supplementation. There was a study that found at a 4-to-1 ratio, so the highest prescription of the ketogenic diet, only 3 out of the 28 required vitamins and minerals were being met from the diet alone. And even at the lower ratio, a 1-to-1, only 12, so less than half. So definitely very important. Your dietitian can help give recommendations. There's multiple different forms out there. Usually you're having to take a few different supplements to meet all of your requirements. The other thing to point out too is that we don't just get carbohydrate from the foods we eat, but we get carbohydrate from the medications, the over-the-counter supplements we might use, even things like cough syrup or Tylenol. Your pharmacist or dietitian or nurse practitioner will help you find the lowest carbohydrate form in these products. Even thinking about chapsticks and toothpastes, these are different things that we need to pay attention to. And sugar-free doesn't always mean carbohydrate-free. So we teach label reading and how to identify some of those tricky ingredients like glycerin and sorbitol that are on labels.
Okay, thank you. So previously, prior to this consensus statement that came out, back in 2009, that was the first consensus statement paper that came out. Recently, this is the most updated version. It's in 2018, where this group came together, the International Ketogenic Diet Study Group came together, and they gave updated recommendations in how to manage patients who are on the ketogenic diet. Prior to this, many centers were doing it differently. However, now there's more of a uniform protocol and way to do it safely. In this new updated one, I want to just point out that prior to this in 2018, they were actually not recommending children under the age of 2 to start diet therapy. However, recently it's found in many of our research or case study reports, we found that it's not only safe and efficacious to use it on children younger than 2-year-old, but it might be preferred because they're the ones that are most susceptible to actually having some response and efficacy. And there was a report that even as young as 6-week-old infant could actually safely and effectively use the diet therapy. So here it talks about all the different epilepsy syndromes and conditions. All are in alphabetical order. And these have been shown to have more beneficial response to ketogenic diet therapy. I'd like to point out here glucose transporter type 1, deficiency syndrome, and the pyruvate dehydrogenase deficiency. Those two types of diagnoses, if your child is ever diagnosed with this is actually our medication of choice, is the ketogenic diet, because these patients cannot break down glucose to provide sufficient energy. Therefore, they probably have seizures due to those specific diagnoses. So if you see those specific diagnoses, those are things that you would want to tell your neurologist that the diet is actually preferred treatment of choice. And there's a list of all different types of epilepsy syndromes on there that are also used for diet therapy. And these are several other indications that have been reported as moderately beneficial as well. However, there are absolute contraindications for diet therapy. Not everyone can be a good candidate for diet therapy. So patients who are unable to break down fat efficiently would be contraindicated, or patients who have primary carnitine deficiency and things like that would not be good candidates for diet. How would you know? You would then have to speak to your primary neurologist or your diet therapy team. They'll be then getting a pre-diet evaluation, which will consist of screening labs. All it is blood and urine, and that will let them know whether or not you are an appropriate candidate and the diet can be managed safely on your child or yourself. Usually during this pre-diet evaluation, not only do they get labs, they also screen for adequate fluid intake, as we know that the ketogenic diet or any diet therapy can also cause kidney stones and things. We look at GI side effects like reflux, constipation, malabsorption, and any food allergies or intolerances, the parental or patient reliability and compliance. And we also ask for a diet record to see what you're currently doing so that we can kind of mimic what you're doing and know how many calories you take on a daily basis. So starting diet therapy, again, like Jessica said, for ketogenic diet, we would start patients inpatient. Those are for children. However, for adults, we do not start adults inpatient unless they're, medically we think that it's appropriate to start them inpatient. However, for most children, for all of children, we will start ketogenic diet inpatient, but for adults, mostly we would start them outpatient. And for modified Atkins diet or any LGIT or any modified keto, it would be started outpatient. An inpatient ketogenic diet admission would take usually about 3 to 5 days. And we'd monitor everyone about every 3 months thereafter, monitoring labs as well. So something to point out, if patients are on any of these medications when starting the ketogenic diet, it would just be good to know and point this out to your primary neurologist or treating provider. As pentobarb, we know IV can have some interactions with the ketogenic diet, as there is carbohydrate in there. Zonisamide, topiramate, acetazolamide, those also are carbonic and anhydrase inhibitors. and they can also interact with the kidneys, so would increase your risk for kidney stones. Valproic acid may cause increased biosynthesis in carnitine, so therefore you may be at risk for carnitine deficiency, which the ketogenic diet may also do as well. And other drugs like oxcarbazepine, steroids, high carb medications like dextrose, mannitol, lipids are also something that you should be aware of. So side effects. The acute side effects, which are usually seen within the first 2 weeks of initiating the diet, whether it's a ketogenic diet or a modified Atkins diet, the red ones are the ones that are most common, like hypoglycemia, which means a low blood sugar level, lack of energy, excessive acidosis, nausea, and vomiting. Usually those are seen within the first week or right when you're starting the diet. And our bodies typically acclimate to this change in metabolism from carb metabolism to fat metabolism within the week, and your side effects then do subside. However, chronic side effects do continue, and that's continued to be managed, and it's constipation is one that's most common. Others are all listed there for you.
I don't know if you're going to clarify that, but on the keto diet, HDL goes up, LDL goes down for cholesterol, which is generally what you want. You want higher HDL, you want lower LDL. The total cholesterol may go up, but cholesterol is really very healthy way to eat.
Yes, for some of our patients, the high cholesterol is actually the good cholesterol that goes up. In the first 3 months of the diet, you'll see a trend, an increase in all types of cholesterols, the total cholesterol, the HDLs, the LDLs, the triglycerides. However, it's not sustained. Over time, in studies, it shows that actually it comes back down to a baseline, and sometimes there is even improvement in patients' cholesterol levels. So in children, we do typically see an increase in overall cholesterol in all parts, the HDL, the LDLs and things, but in a lot of our adult populations, actually, they come in with fatty liver even, and they actually have improved cholesterol levels being on a ketogenic diet or a diet therapy. Thank you. So does the diet work? A lot of times people are challenged and they ask, does it really actually work? And that's why we have studies that have proven that it has worked. Here in 2008, Dr. Elizabeth Neal and Helen Cross and others have written a nice paper about the ketogenic diet for treatment of childhood epilepsy, a randomized controlled trial. In this study, there were 150 patients who were assessed for the eligibility of this study. Of the 150 patients, only 145 patients were enrolled because 5 were excluded due to not meeting the inclusion criteria, etc. And of those 145 patients enrolled, 73 of them were randomly assigned to the diet group, and 72 of them were randomly assigned to the control group. Of those, a few did not participate in the study due to not doing the dietary treatment or not wanting to do it, changing their minds, things like that. And 65 of those then received treatment, were in the treatment category, and 64 of them went into the control period. From there, only 54 were included in the final analysis because 10 discontinued out of the diet and 1 was excluded due to inadequate data. From the 64 participated control patients, 15 were excluded because there was inadequate data. So in the final analysis, just remember that it should be 54 patients that we're looking at that were in the diet therapy treatment group, and 49 were in the control group. All of these patients were from ages 2 to 16 years old. They had daily seizures, or at least 7 seizures or more within the week, and they failed 2 appropriately chosen anti-epileptic drugs or more. They had various epilepsy syndromes, and both focal and generalized epilepsies, and in this study they had a 3-month treatment period. Again, these patients were all randomized, but they were not blinded. So the results shown here, the N value is 73. And remember, like I pointed out here, the final analysis should actually be 54 and 49. However, here it's showing N value of 73 and 72, which included ones that were excluded out of the final analysis. And to point out here, I extracted that data and looked at the 28 of 54 who are in the final analysis actually responded and completed the diet, had greater than 50% reduction, and 5 of the 54, which is 10%, had greater than 90% reduction. Although here it's showing that 5 of 73 is 7% of greater than 90% reduction in seizures, and 28 out of the 73 patients in the diet group, which is 38%, showed greater than a 50% reduction in seizures. This was definitely a significance in comparison to the control group. The control group showed that there were no patients who had greater than 90% reduction in seizures, and there were only 4 of the 72 patients who had greater than 50% reduction in seizures, and 68 of the 72 had less than 50% reduction in seizures. And so that's why we know that the diet therapy does work. And here's some information for UCLA if any of you guys are interested in the process for referral. We do see both adults and pediatric patients. The referral process is just discussing with your neurologist and then having them schedule you guys or refer you guys to UCLA for a consultation. You can call at our appointment center line or our office. And again, during that consultation period, you'll be evaluated by a nurse practitioner and a dietitian, and they'll give you guys resources. They'll go over your labs if those labs are already completed, or they'll order the labs, and they'll give you nutritional goals for you to work on prior to starting. So it's the consultation prior to starting the initiation of the diet therapy. Here's some additional information and resources. And here's information about CHOC's ketogenic diet therapy program.
Right. So we have a multidisciplinary clinic at CHOC, and we only treat children. So unfortunately, we don't treat adults. It's a multidisciplinary clinic where we have our epileptologist, nurse practitioner, dietitians. We have a social worker, and what I feel like is unique to our program as well is we have pharmacists that help review the medications and over-counter medications as well. For our appointments, we have our phone number up there, 714-509-7601. You would obtain a referral from your primary neurologist, and then you can call the 7601 number to schedule a visit, and it will be a multidisciplinary visit, 1-hour consultation with our team. And then we would just like to acknowledge our other members that aren't here today, or they might be out in the lobby of our ketogenic programs at UCLA and CHOC as well. And we'll open it up to questions.
On the MAD diet for adults, do you stop the anticonvulsants, or you do both, and you mix with anticoagulants, your blood thinner?
So the question was whether or not we stop anticonvulsants with the modified Atkins diet, and if we can use it with anticoagulants. So no, we do not stop any of the patient's medications. We only start and initiate diet therapy and review. We also review the medications that you're on. So if there is any contraindications or any probable contraindications, then we will discuss with you what those contraindications or concerns would be with your medications. However, we don't stop any of the medications. We actually leave that up to your primary neurologist, and we consult with your primary neurologist, and we'll work together with your primary neurologist, but we typically never recommend to discontinue any medications without your doctor's permission. And with the anticoagulants, yes, we can work with patients who have anticoagulants, and we'll work with any providers. So if there is any blood disorders, we will talk to either your hematologist or, and we will discuss that, any concerns. There are some concerns for anemia on the ketogenic diet or the modified Atkins diet, so that's something that we do discuss with you as well and your providers.
My daughter is 6 years old and on the main diet. And I'm curious to know what your thoughts are about sprouted flour. And on the kind of a twofold question, are you familiar with the Feingold diet and what your thoughts are about that?
The what?
Feingold?
The Feingold diet. That's the first time I've heard of it, so I apologize on that. But for the sprouted grains, it probably depends on what carb level. Many dietitians will modify the diet, modify the modified Atkins diet to be specific to that individual. And so sometimes we will allow higher amounts of carbohydrate, maybe even up to 40 grams per day. So it really, it's individualized. We have fit in some higher carbohydrate foods. Some of my families really want beans, and so we're going to make it work. The volume's going to be smaller. So you can utilize your carbohydrate for those higher carb foods. The volume typically is just smaller.
On your list, it says we had a list of your anticonvulsants like
Maybe the syndromes, do you think?
there was some anticonvulsants that I was on, and let me see. Okay, yeah, I'm on zonisamide. Okay, I'm having a problem right now with my insurance because they won't approve this other medication I'm trying to get because the problem is it involves dilatin, and they said dilatin and zonisamide don't get along. Mm-hmm. You know what I mean? There's a problem like that, and it's like it's funky.
Mm-hmm.
You know what I mean?
I would recommend, if you're having trouble with your medications, to speak to your primary neurologist and the interactions.
Yeah. And he said, well, you'll only be off that for 12 weeks and this and that, we'll put you on it. I said, my neurologist wants me, so I don't get hepatitis or whatever like this. So, you know what? I'm on clonazepam as my anticonvulsant. Sick enough, but I mean, there's a problem with my insurance like that. And that's why I'm here talking to you about that. So.
We can talk later about your medications or something. Is there any other questions related to diet therapy?
We can talk later.
Okay.
Does the ratio for keto, I've actually never done it before, I'm very curious about it, but I am a very active individual. Does the ratio change for those who live very active lifestyles?
So yeah, it's calorie dependent, and so if you require higher calories because you're exercising or very active, often you get allotted more carbohydrate and protein than somebody that's sedentary. Mm-hmm. And if you're interested, Jeff Volek has done the most research that I know of with even elite athletes, endurance athletes, and has written some books. Jeff Bullock, so that might be a good resource for you.
Is he here or is the resource online?
Yeah, he's not here, but yeah, has a few published books that would be towards more of the athlete. Mm-hmm. Volek, Volek, I believe. And then I think you had a question. Go ahead, sir.
I've been actively doing traditional keto was a little too much for me, but I've been actively doing the modified Atkins and been in ketosis for about 3 years, and I love the lifestyle. You mentioned I'm on the modified Atkins. You mentioned modified keto. I don't know what the difference is.
Yeah, it kind of gets tricky with all of the names because I feel like they're all part of the ketogenic spectrum. And a lot of times dietitians will take bits and pieces from each diet therapy and kind of mold it into what would be doable for individualized patients. The modified ketogenic diet is lower ratio. So they consider the classic ketogenic diet as a 3-to-1 and a 4-to-1. The modified keto is more of the lower ratio, a 1-to-1 and 2-to-1. And oftentimes with a modified ketogenic diet, you might, instead of weigh things on a gram scale, use exchanges. So 1 ounce of protein would be 1 egg. So you get X amount of protein ounces per meal. 10 grams of fat would be a tablespoon of butter. And so they break it down into household measurements. So you're still trying to achieve the 1-to-1, 2-to-1 ratio, but it's not as specific as weighing things on a gram scale.
Modified Atkins is definitely going to put you in a deeper level of ketosis.
So modified Atkins, generally speaking, is close to a 1-to-1 to 2-to-1 ratio. So they're very similar in terms.
Atkins or modified keto?
So both. Usually for modified Atkins, even though we're not calculating the ratio, usually when we do our education as dietitians, we're typically giving kind of ballpark ideas of how much fat, how much protein the patient should have, and it usually calculates between a 1-to-1 and a 2-to-1 ratio. Now some might go higher, it all depends on how much fat you can tolerate.
Yeah, I mean, I'm comfortably on probably a 3-to-1, and I've always considered that, and in literature, you see that more as like a modified Atkins versus 90% fat, which is something like a traditional.
That would be a 4-to-1 ratio is 90% fat. Mm-hmm. Yeah. So yeah, the modified keto I think has only been presented maybe in the past 2 to 3 years. I think it's pretty new, but it's just trying to make the classic ketogenic diet more doable, especially for adults and teenagers.
You know, it hasn't worked to control my seizures, but I love the lifestyle. I'm still doing it. But one thing that's really popular in the keto community are exogenous ketones. And so a lot of people leverage them, use them, love them. They put you into a deeper level of ketosis. And so I'm wondering, and I use them sometimes. So with the modified, Atkins, I hover, probably 1 millimolar to 2 millimolar, somewhere in there. But if I go into exogenous ketones, consistently, I can get a much deeper level of ketosis. And people, generally, you're going to say, if you can handle 4-to-1, you're going to be in a deeper level of ketosis and might have a better chance of controlling your seizures. Do you think it's worth experimenting with modified Atkins, I've tried it with exogenous ketones, trying to get as deep as I can. Deeper into ketosis, you might as well just try and pump up those molars, get a little deeper, and see if that helps.
I don't think it hurts to try increasing your ketosis. I've actually seen, in ones that were seizure-free, I would say that my experience has been that their level of ketosis has between 3 millimoles per liter to as high as an 8 millimoles per liter.
Yeah.
And these are just in my pediatric patients. So those are my experiences.
Great, thank you.
Any other questions?
Just one last comment, and I know it's probably pretty controversial and shocking when people hear it, but the carnivore diet is getting more and more popular, and I know someone who tried, keto with epilepsy, who's also loved the lifestyle, was doing modified Atkins forever, was still having the seizures, and then she decided just to give it a try, went carnivore, and her seizures have been controlled for a year. Wanted to see, and she just started eating meat, and I think she might eat eggs also. But, almost like one of those diets, elimination diet. Maybe
Yeah.
there's something else in
Like
her
triggering,
that
yeah.
plus the ketosis. Seizure free.
Yeah, that's great. She probably reduced her carbohydrate, right? If she's just eating the protein foods. So she might have been in a very small ketosis, which might not be detectable by urine, but probably by blood, we could have seen some ketones. But then, a lot of our families will try to avoid dyes and artificial ingredients because they feel like those are triggers. So when you eliminate the processed foods, you're eliminating some of those additives. Interesting. Well, thank you everyone for coming. We'll stay here maybe for a few more minutes if anyone else had some questions.
Yeah, we'll
Thank
probably
you.
be in the back.
Yeah.
Alrighty, thanks.